Very warm welcome everybody to the celebration event for the impact of our collaborative research for UEA Health and Social Care Partners for the past year. We're delighted to be hosting this of our first annual conference events this year virtually and hopefully next year in person. My name is Carrie Jackson and I'm Research Director for the UEA Health and Social Care Partnership, and this event is a real celebration and testament to all of our colleagues who are here today and to the UEA Health and Social Care Partners team. That's Heather Judson, Bianca Bianchi, David McCabe and Sarah Walker, without whose help we wouldn't be here today. So thank you very much for joining us. I am going to move through the presentations, and our first presenter is Professor Charles French-Constant, who is Pro Vice Chancellor for the Faculty of Medicine and Health Sciences. So over to you, please, Charles.
Thank you, Carrie, and good morning, everyone. I'd like to welcome you all very warmly to this celebration event of the partnership. So the partnership was the brainchild of our predecessors, Dylan Edwards and Mark Hitchcock. And I think it's a brilliant vision, the idea being that we could perform research in a fully integrated way across all of our partners involved in healthcare delivery across the Norfolk and Waveney region and beyond. Because in the past, I think, I'm sure you'd all agree with this, that interactions have often been one way towards the university. And I think this partnership changes that. The vision is that this will change all that by making sure that our joint research works both ways and addresses what really matters to the people of Norfolk and Waveney and beyond. So since I came to UEA, which was a year ago, almost to the day, in fact, I've been working and executing a vision to try to increase the impact and power of research. And the partnership is absolutely critical to that strategy. So what I'm trying to do is create 4 research centres within the faculty. Those are biomedicine and mental health, healthy ageing, epidemiology and health evaluation, and health and care innovation. And the vision is that those 4 centres are underpinned by 2 critical supporting structures. One is the Citizens Academy to address the really critical issue of public involvement, and we'll hear more about that later from Caitlin Notley. And the other one, of course, is the partnership. And the idea is that the partnership, which is now being led by Carrie Jackson, is to make sure that the partnership works by enabling us to identify what the key research questions are and then put in place the teams to address them. So the first has already happened, as I'm sure we'll hear later, and the partnership has very successfully identified key research priorities. And what we're now doing is putting in place the mechanisms whereby we can create the teams to research those questions. And the partnership then has the critical additional role of enabling us to get the seed corn funding that we need to get these projects underway, so that we can then apply for the big bucks, as it were, the NIHR grants and grants from other key national funders. So this is a fantastic set of actions over the last year, and I'm personally really delighted with the success of the partnership and really excited about its critical future in the research vision across the region. And I'm delighted to see so many excellent projects showcased today. And with that brief introduction, Carrie, I'll hand back to you.
That's lovely, Charles. Thank you very much. So I'm now going to move us into a presentation from Professor Sally Hardy, who's Dean of the School of Health Sciences. Over to you, Sally.
Thank you, Carrie, and to Charles. Welcome everybody to the celebration. And it really is a celebration of effective partnership working. So what I thought I would do as part of the context within which effective partnerships are so important is to take the opportunity to map out where and how UEA has a significant place within the changing political and governance of our health and social care services, workforce and talent pool for undertaking effective collaborative research. Heather, next slide, please. So what is an integrated care system? I chose the image of oil and water here because it does rather feel as if we are having a big shake-up in order to bring together what has previously been separately funded, governed and allocated resources and structures for delivering health and social care across the UK. So on the 1st of July, just 3 days ago, it is official that policy has changed to have health and social care organised through what are called integrated care systems. So if you will indulge a few minutes, I'll try and walk you through that changing landscape. Next slide, Heather. So what we're seeing here is an opportunity for utilising the political changes and how health and social care is being governed and financed for its significant impact on and showcasing effective partnership working. In the east of England, we now have 6 ICSs, and these are governed by integrated care boards, which is where the financial decisions and resource allocations are being identified and implemented. So for us, our local ICS is the Norfolk and Waveney region, which spreads from Great Yarmouth literally right the way through to King's Lynn across the top of east of England. So NHS England have begun to merge with Health Education England, which were the previous commissioning bodies that would work with higher education institutes to commission workforce and education that would influence the workforce needs of health and social care. So our role as an HEI is to ensure that we can be the catalyst through which effective partnerships take place. And the UEA Health and Social Care Partnership is perfectly placed to achieve this. Next slide, please, Heather. So outlined on the government websites and now our very own integrated care system in Norfolk and Waveney are the core purposes of an ICS. And within these 12 bullet points, you can see clear rationale for providing a focus where UEA can and does address health-related challenges of our populations and where and how we can influence service level priorities through our research and academic portfolio. I've highlighted here some key words that again I think are important for us to consider. It's about improving outcomes in population health and health and care service delivery models. It is about tackling inequalities in the experiences that our patients, populations, citizens have and where and how they access and experience that care. It's about enhancing productivity and ensuring that public resources are being utilised effectively and so that people are seeing value for money in where investments are being made. It's about supporting the NHS to have a broader understanding of the social and economic implications on health inequalities in our region and beyond. And importantly, it's about collaborating to initiate and enable and sustain effective health and social care delivery that really can tackle complex health challenges. And for UEA, that is not just on our local doorstep in the ICS, but where and how we can influence this agenda nationally and internationally. Next slide, please, Heather. So here are some very positive verbs that are being used to describe and outline 10 priority outcomes that the ICS is being required to engage with. And again, I think you can see from these words, supporting, growing, valuing, enabling, educating, leading, are all words that I would like to see, and we know are where the strengths are across UEA. Next slide, please, Heather. So this diagram looks a little bit like a cell under the microscope, is how the integrated care system is mapping itself. So you can see here the large A's identify our acute trusts in our area. So the NNN, JPH and QEH. We've also got the Mental Health Care Trust there, Norfolk and Suffolk Mental Health Care Trust, and the community trusts, Norwich Community Healthcare Trust. And then within these integrated care plans are the primary care networks. So they are clusters of GP practices, social enterprises, and community-driven aspects that all influence health and social care and how our population are being served. And then on the outer circle, the square C, is where and how we link and integrate across council-driven decisions, which largely have been related to social care settings. But what is obviously missing from this diagram is UEA. Where and what role does the HEI have in this newly structured integrated care system? Now, some of you that are more familiar with this profile and the governance structures know that actually the finances are not necessarily fully integrated, as the PCNs have a separate budget for their research and education at this point in time. But again, I think this is a political landscape that will now work at pace to make big decisions that will influence what, where and how we engage with our local partners. Next slide, please, Heather. So what does this mean for us at UEA? So we have been beneficial in the East of England for Health Education England and NHS England Innovation to secure a 3 million investment in HEIs. So 6 HEIs across the East of England located to those 6 ICSs have been given £3 million to achieve the priority of ensuring HEIs are recognised as anchor institutes within this integrated care structure. So what that means for us is we need to be showcasing where and how we can lead and establish and continue to educate and research in areas of system level transformation. So where and how services are being wrapped around the individuals, the citizens we serve, and the communities within which we live, work, and thrive. And this we know can be achieved in our already well recognised applied board to bedside to bench research that takes place across FMH and beyond. It's our evaluation expertise and our ability to gather large sets of data and translate that to allow the system to understand what, where and how future ways of working, strategies and service delivery models can be developed and understood and mapped. And then there is a huge agenda around workforce. As we are a key player in educating the future workforce for our system, are we providing the right courses, the right training, and how do we help to ensure the system is functioning well within a workforce that is fit for purpose? And then, of course, there is the huge agenda of the research that we already undertake and continue to undertake around health, tackling large global health inequalities and public health risks, and a chance for us to showcase the expertise that we have as a coastal and rural ICS. So to conclude, the ICS at Norfolk and Waveney brings together NHS, local government, voluntary, community, social enterprise sectors with partners such as UEA to really focus on and tackle wide social and economic determinants of health. No better time now than for the UEA Health and Social Care partners to showcase the work it has already established, but the future work that we can continue to influence the integrated care systems, not just in our locality, but as I said, on a national and international scale. Enjoy today, and I hope that the conversations we have will really stimulate those progressive conversations and partnerships as we continue to work across this changing landscape. Thank you.
Thank you, Sally. If you could just go to the next slide, please. Next slide, please. Thank you. We've got a little bit of feedback on the sound. Hopefully that corrects itself. So with that in mind, thank you very much, Charles and Sally. I'm just going to give you a bit of a whistle-stop tour about how the partnership is going to work for the next 2 years to streamline and focus its activity so that we can build together collaborative research and innovation that meets the needs of our local populations. So next slide, please. So the first thing that we have done is that we've worked with all of our current 10 health and social care partner organisations to focus the top 3 themes that we're going to focus on for the next 12 months to address the population health challenges and needs that our partners feel are top priorities. So they are population health management, digital innovation, and children and young people's mental health. So this one slide shows you a streamlined menu of activities that the partnership is going to support over the next 2 years. So first of all, we've got 2 rounds of building capacity for research. So we've got one that's open at the moment and it's just closed actually. So we have one in June this year and one in January of next year. So we're going to be funding collaborative practice-led projects that make a difference in those 3 research themes. The second is that we will be launching a new research scholarship programme in the autumn, which will provide awards for researchers to develop their research ideas. The third is that we're going to be working with the Applied Research Collaborative in the East of England to develop our first co-badged fellowship for clinicians and practitioners who don't want to follow a traditional research PhD, but instead want to be able to support practice-driven projects. And this fellowship, which opens in October and starts in April of next year, will enable the successful candidates to join a cohort of practitioners across the region to learn together in terms of research methods to improve their research projects, receive support through action learning, and have an academic supervisor who can take them through their research project. The next new innovation is that we'll be holding 2 research sandpit events every year with partners to enable partners to bring issues, challenges and research questions to be worked up into research proposals for funding. And that means that they're timed to enable people to take advantage of the building capacity funding rounds. So this year we're going to have our first sandpit in November and the second in April of 23. All of those activities will enable us to develop impact case studies to showcase to the partnership that they're receiving value for money and return on investment. And that's very important that we report that back to the executive board. The next new initiative, which isn't on this slide, is that we aim to grow our associate membership. So organisations can come and join us without necessarily having to put money into a pot. And that's very important because we heard in the ICS presentation that there are lots of new charities, social enterprises and smaller organisations that are joining the integrated care system space who have a real need to have support in terms of developing their research proposals. We're also launching a new website which will profile the work of our researchers through blogs, video logs, news and events. And of course, we have today's annual conference, and next year we're hoping to hold that in person with Professor Caitlin Notley in the Citizens Academy, date to be confirmed. We've also streamlined a lot of the meetings that our partners have to attend. So we are moving to 1 executive board meeting a year, 2 management boards. We're having regular dialogue with our research leads because there are 16 research groups currently in the Faculty of Medicine and Health Sciences that the partners can link to. And we're also strengthening our advisory board with citizens with lived experience. So that's a bit of a whistle-stop tour and enough from me, because today is about celebrating the research that we previously funded in the past year. And we have 6 projects that are being presented today. So I'm now going to hand over to my colleague, Wendy Hardiman and Angela Fletton, who I believe can't be with us today, to tell you about the Charming Research Project. So over to you, Wendy.
Thank you very much, Carrie. So I'm really delighted to present the Charming project, which is a co-production project focusing on supporting multiple behaviour change in underrepresented communities. Can I have the next slide, please? We're really grateful for the support by UEA Health and Social Care Partners. The Charming team is a great team. It's a large team, multi-agency partners, and they include the UEA, the Norwich Institute of Healthy Aging, and the co-production partnership embedded within it, CCG, several acute NHS trusts, community health and social care, mental health trust, also the County Council, public health teams from Norfolk and Suffolk, Norwich City Council and Active Norfolk. So we're a really large team. Could I have the next slide, please? We know that health behaviours have got a big impact on community health and well-being. And we know that people who live in poor communities live on average 19 less healthy years than those living in the wealthiest communities. This is really a staggering difference, and it's largely explained by inequalities in health behaviours, and especially what we call the big 4 behaviours, which are excessive alcohol consumption, smoking, sedentary lifestyles, and unhealthy eating behaviours. So it's really important, if we are to reverse this, that effective prevention efforts are really key to that. Next slide. We've known for a long time that these 4 big behaviours cluster. So, for instance, if you are smoking, you're also more likely to drink harmful levels of alcohol. Those big four behaviours cluster especially in socially deprived communities, which we're working with in the Charming project. And this situation has really worsened by the COVID pandemic. And we've known for a long time, more than 10 years, that these behaviours cluster. But we still don't know how best to support change in multiple behaviours. Usually we tend to focus on single behaviours, and services also reflect this situation. And also there's very little research evidence actually about how to support multiple behaviour change. Next slide. So what we're aiming to do in the Charming project is, as you've seen, to work in partnership with multi-agency stakeholders, the Charming team, and a lot of stakeholders beyond that, and people in underrepresented communities with lived experience, to generate insights that will inform large research funding applications and also will influence practice and policy. And our key aim is to identify promising ways to support multiple behaviour change in underrepresented communities which are currently not used in practice or maybe are not maximized to their full potential. So there may be services out there which are evidence-based and really working, but are not linked up. And also those insights or those initiatives should be judged to have great potential for improving community health and well-being, and also obviously to reduce service demand. Next slide, please. So Charming consists of 2 stages. We started in February this year. We're in the middle of stage 1, where we're collecting and summarizing views about supporting multiple behaviors and linkages between those behaviors, and also aiming to identify best practice in our region. And we have been holding scoping meetings with stakeholders who work with the communities. We're currently holding discussions with people with lived experience from the communities. And another component of this stage is to draw up a system map with multiple behaviors and linkages between them and common influences. And then in the second stage of the project, we aim to reach consensus on promising ways to support multiple behavior change through stakeholder workshops, which will then influence research as well as practice and policy. Next slide, please. So we've been, the scoping meetings with stakeholders have been focusing on the following topics. We've been discussing the big 4 behaviors, but also asked stakeholders whether there were any other behaviors or issues that they thought were also equally important or more important. And we've been trying to find out the connections between all those behaviors. We've asked the stakeholders about their experiences with supporting multiple behavior change, best practice, and also asked them key research questions that they thought should be addressed. Next slide, please. And we're currently having discussions with people from underrepresented communities, and we're asking them about their views on health and well-being, and particularly in the context of daily lives and stressors. As you all know, these are tough times, cost of living crisis. There's a lot of other things going on in people's life, which probably reduces their opportunity and capability to adopt and maintain healthy behaviors. We're asking them whether they actually think about these big 4 behaviors at all, or whether they're more important behaviors or issues that that matter more to them. And finally, we're exploring with them how they self-manage health behaviors and what are the triggers and motivators and support for adopting and maintaining healthier behaviors. Next slide, please. So the progress so far, as I said, we've been running this project since February. We've spoken with 42 stakeholders from a wide range of organizations, including community, voluntary organizations, local government, health and social care. And we initially planned to speak with probably 14 stakeholders. So it really shows we've had massive interest in this topic. It's really something that obviously a lot of people are thinking about. We're currently having discussions with people with lived experience in urban, rural and coastal communities. And we're having these discussions in community assets, so for instance, community centres, but also an allotment. And we're using creative approaches to stimulate discussion, which has been working really well. And as I mentioned earlier on, we're currently designing a systems map, which shows all the linkages between those behaviours and common influences that we might target in our future interventions. Next slide, please. If you could do the first bits. So a great example of demonstrating the value of partnership working, even at these early stages, is from Suffolk County Council Public Health team, who are one of the key partners in Charming. And they're currently reconfiguring their public health public health services and support as well. And it sort of evolved over time from having services, really, service-based behaviour change support, independently commissioned, really siloed approach, focusing on single behaviours. And then a few years ago, about 5 years ago, they moved to an integrated lifestyle service where a single provider provided all these services, holistic, person-centered, but still having a single behavior change approach, which was a problem both for the clients as well as the providers in the services. And they're now moving to a different way of working, different way of reimagining healthy behaviors, which really is far more a place-based, community-based approach rather than behavior change support driven by services, really paying attention to people's context and the wider determinants of health. It is theory-based, informed by the Combi model, and really takes a holistic, integrated approach focusing on multiple behavior change. Next bit, please. So a lot of work has been going on already, and as you can see on the right-hand side here, case studies, focus groups, surveys, a lot of work has been going on to inform this thinking. Final bits, please. Thank you. So the insights that have been generated so far, and these are insights that the County Council Public Health Team has generated, but also in Charming, we're finding the same insights of talking to stakeholders in the communities. People like to embed behavior change support into fun activities that are done in a group, and we're hearing that's really where behavior change is happening. Next one, please. People really value support from others going through the same thing. This is really something that helps people to adopt healthy behaviors, but also to maintain positive change over time. Next one, please. People like behavior change support close to home and easy to access and in a supportive environment. Next one. People want longer term support. Because we all know adopting change is difficult, but maintaining positive change over time is even more challenging. But longer term support really helps to develop friendships, and those friendships and social support in turn help sustain behavior change. Next one, please. People also wanted to support that is low cost or free of charge. And finally, people are not just looking for one thing. They want also an integrated approach and focusing on multiple behavior change. So I think this is a really lovely example, a sort of a really unique opportunity where the insights from the work that's been done by the public health team at Suffolk County Council is informing our work in Charming, but also the insights that we generate as part of the work in the Charming project is informing already the how Suffolk County Council reconfigures public health, and really there's an immediate real-world application from the work happening in Charming. Next slide, please. That's my final slide. So the outputs and anticipated impacts, and as I sort of illustrate, the impact is already happening. We want to generate promising ways to support multiple behavior change, which will inform the research agenda of the Health and Social Care Partnership and also the Norwich Institute of Healthy Aging, as well as informing innovation in practice and commissioning of services. We will produce an evidence briefing for all the partner organizations and the stakeholders who have participated, a summary for people with lived experiences. And lastly, but very importantly, we're already doing that, promoting increased capacity and collaboration between partners in supporting multiple behavior change in communities who can benefit the most. Thank you.
Thank you very much, Wendy. What a fabulous project, and we're delighted that you were able to be here today to present the work in progress. It just sounds fabulous and exactly what the partnership is all about. So thank you. Next, I'm going to introduce you to Dr. Simon Hammond and Ella Mickleborough, who are going to talk to you about the work of the Lantern Research Group. So over to you, Simon and Ella. Thank you.
Thank you, Kerry. Hi, everybody. Thank you very much for joining us today. Next slide, please, Heather. So we're going to talk briefly about Lantern. So Lantern is the Looked After Children's Mental Health Research Network. Next slide, please. And the idea behind Lantern really was to bring lots of organisations from across the region together in one network. The idea being that we can kind of build capacity across and within those network contacts, but also consolidating this around 3 key themes. So the themes we have at the moment are better evidencing practice innovations, promoting positive mental health, and also supporting better online lives. And across these 3 themes, we have one mission. That's to make this region the most mentally healthy place to be a care experienced child or young person in the United Kingdom. So what hopefully comes through with the work we've been doing, the Lantern group and the network, is that it's very much locally orientated work, locally generated work, but has a national and potential international implications. So we were delighted, next slide please, to receive a research capacity funding piece of money from the Health and Social Care Partnership. And with that work, what we did was really take our ideas to the variety of different partners and discuss them and really hear back from them and work with those providers and those colleagues and the different organisations to really develop a research area in a project called Limitless, which Ella is now going to provide a brief overview of.
Thank you, Simon. So Simon and I are currently working on the Limitless project together, and what that is a realist review of life story work that's carried out with adolescents who are care experienced. So life story work is an ongoing piece of work where the young person is supported to make sense of their lived experiences, and where memories are secured by writing them down, and artifacts like photographs and significant objects are collected. And by having conversations about their lives and by having access to a collection of memories, it has a positive impact on young people's ability to construct a coherent sense of identity, and it promotes positive mental health. So although life story work is highly valued by young people and adults within their support network, practice is really inconsistent, and some young people experience very good life story work, while others receive ill thought out work, and other young people with care experience don't receive any life story work at all. And some of the reasons for this is because there's no clear guidance on how or when life story work should be carried out. And when you go to the literature, the evidence base is really lacking. So there are surprisingly few studies done in this area, and those that there are, they're often of low quality and they have small sample sizes. So from such a weak evidence base, it's really difficult to know with any certainty who life story work works for, when and how it should be delivered. So could I have the next point, please, Heather? Thank you. So in 2020, Simon was awarded research capacity funding of £5,000, and this funding really provided the seed from which Limitless study has grown from. So the funding provided resources to carry out a scoping review of life story work with adolescents, and that provided a map of the body of literature within the area. Could I have the next point, please? Thank you. And so the scoping review was published within the Journal of Developmental Child Welfare. And can I have the next point? Sorry. Thank you. And also it led on to, by carrying out that scoping review, it really helped to inform the writing of a funding application to the National Institute for Health Research's Research for Patient Benefit Programme. And the scoping review provided a good foundation to inform that funding application, which really helped to secure the funding to carry out the Limitless project, which is the 16-month project started in September 2021, and it's hosted by Norfolk and Suffolk Foundation Trust and led by the University of East Anglia. And the work carried out with the research capacity funding meant that we started the Limitless project from a really good position. So we had a search criteria already established, and we were really able to hit the road running at the beginning of the project because of the proprietary work that had already been done. And we also were able to publish our protocol medical journal open, and we were able to do that really early on in the project, which was helped by the prior work carried out within the original scoping review. Could I have the next point, please? Thank you. And then work on the Limitless project would also hopefully lead to securing funding for further projects in the life story work area. So we've currently got a funding application under review with the Sir Halley Stewart Trust, and that's to conduct a 12-month project working with members from the Limitless project team and care leavers who will be providing consultation. And that will be to conduct a realist evaluation of the Caring Life app. And Caring Life is a digital application used for low intensity life story work, and that's being piloted in Greenwich. But currently it has no practice guidance going alongside it, so there's no guidance on how it should be used with young people with care experience. And if the funding application is successful, the project will look at foster carers and young people's views on using the app, as well as looking at some routine outcome measures pre and post using the app, and hopefully will, with the evidence from Limitless, will help to write some practice guidance that can go along with applications like the Caring Life app. We're also preparing a funding application for the National Institute for Health Research, Health and Social Care Delivery Research Programme. And that is for a wider scale evaluation looking at the effectiveness of low intensity life story work. And the findings from the Limitless project will inform the writing of this application, and we intend to apply for between £600,000 to £700,000. And the plan is to submit that application in March 2023. Could I have the next point, please, Heather? Thank you. And the project isn't just about academic outputs, but it's also having and will continue to have real world impact as well. So because of the work being done on the Limitless project, Simon recorded a podcast for Children's Mental Health Week for the research edition of the NSFT podcast, Mental Health and You. And that was promoted on Twitter and Facebook and reached both regional and national audiences. And could I have the next point, please? Thank you. And also the Limitless project will inform the writing of best practice guidance to optimise practices in the delivery of life story work. And that will be rolled out nationally from March 2023 onwards. And the aim is to improve practice to promote positive mental health outcomes for young people across the region as well as further afield. So from the original research capacity funding of £5,000, it's provided a springboard for developing the Limitless project as well as other life story work projects that will make real world impacts. Yeah, thank you. I'll hand over to Simon.
Thank you, Ella. Yeah, just to build on that point, really, thank you very much, Ella, really comprehensive. So as we've seen, the research capacity funding really did, and it's called a C-core funding, I guess, in other areas, but really did kind of blossom out in lots of different directions. And as we move to the next slide, what we'll also begin to see is how this sort of thing has actually reached the work, or has allowed the work of Lantern team members to really go in lots of different directions, not just around life story work and digital life story work, but also kind of digital and young people who are in care experience young people more broadly. So one of the things we'll be doing, again, with the platform that the RCF, the research capacity funding, has provided, and also that the Health and Social Care Partnership has provided, is also become involved in the UKIS, the United Kingdom Centre for Internet Safety Group, the Vulnerable Users Working Group in particular. And one of the things we did early doors was contribute to the launch of the Digital Passport. And as you can see, this is hosted on the gov.uk website. So again, we're looking at local issues, but then magnifying how those go across at a national level and impacting clearly at that level. So again, very briefly, Digital Passport is based on my work around digital resilience, again within this particular population, and it helps carers to safeguard the online experience of children and young people by being aware of the young people's capabilities, but also kind of access preferences and technologies. And since its launch in 2021, it's been downloaded over 1,000 times by the various different people and professionals involved in that space. Next slide, please. Next point, please, Heather. So again, another kind of branch off from this work. So what happened, I think we started to really gain momentum and capacity in this area. We started to look at the online lives more broadly, this group. Particularly, again, we were launched around the kind of COVID, first COVID wave. And again, there's really a big interest and awareness of increasing online presence of this group. So we created with our partners, the Care Leavers National Movement, and also Fostering Network and colleagues from the Social Work School, an index of online harm. So again, we contribute to the one there around care experience children and young people. Again, this is something that provided practitioners with real world guidance and evidence of how to make better decisions in relation to supporting children and young people's online lives in this space. Next slide, please, Heather. This also then led to a funding partnership between ourselves, the Foster Network, which is the UK's largest fostering provider, and also Internet Matters, who are one of the leading internet safety organisations in the UK. And we were funded £150,000 from a Nominate Social Impact REACH programme. And this was to create an online CPD accredited course, particularly aimed at raising the skills and awareness of people working in the social care space, or indeed anybody from the rainbow of adults that supports children and young people with care experience. The course launched at the back end of last year and has been accessed by over 5,000 unique visits. And myself and colleagues from the School of Education and Lifelong Learning are undertaking a process evaluation of the course at the moment. So again, we can see how being in this space has really kind of allowed Lantern's reach to really blossom. And the final example of this is the project we've completed most recently, which is entitled Produced a Report called Changing Conversations. And it's really important at this point to mention that this was supported by the Health and Social Care Partnership, particularly in relation to the Young Academic Summer Internship Programme. And so we're really indebted to Freya Boswell, who was the student who was included in that programme, and she was a massive help in terms of collecting the data and analysing the messages and appeared on the report itself. Very briefly, again, we were interested in exploring the connected lives of vulnerable children and young people, and we spoke to a variety of professionals within and beyond the educational setting. As you can imagine, particularly in the integrated care system space, these are a group of people that really do kind of transcend those kind of false silos of health and social care. And the report was launched in 2022, and we spoke to 30 professionals and children and young people and the parents of those groups to really think about what was going on there for them. Now, the report itself was launched by MP Victoria Adams, I believe, who was the key pioneer in this particular area. And the report found that professionals can struggle to engage and support vulnerable young people in their connected lives. This is because they often focus on risk, especially when it comes to digital with this group. As a result, professionals were in danger of providing less support as opposed to more to this vulnerable population. And yet when we enhance or embark on really bringing digital resilience to life, the vulnerable young people can thrive in this space. So again, that's a final area really of our work. So I just want to kind of leave by thanking the partnership for their support and really encourage those people in attendance today, and also those people in the various trusts and different organisations that, £5,000 sounds quite a lot when you say it like that, but actually if you look at the kind of the outputs and the reach we're having and will continue to have over the next 3 to 5 years, I think it's a really worthwhile investment. So thank you very much for your time.
Thank you very much, Ella and Simon. And it is, as you say, great to see that a small pot of funding can lead to such massive impacts for vulnerable young people. So it's brilliant to hear about your work, and people can read about it in the report. Thank you so much. Next, we're going to move into hearing about the project Answers, which is assessing the social needs and well-being of young people with pre-existing mental health needs post-pandemic. And the lovely Bonnie Teague and Bryony G from Norfolk and Suffolk Foundation Trust are here to present their work. So over to you. Thank you.
Lovely, thank you. Thank you for the lovely introduction. So we're here to talk about Answers study today, which is a collaborative between young people and health system partners to support young people's mental health needs across Norfolk and Suffolk. Next slide, please. So Answers originates from the increasing body of literature, both nationally and globally, that shows that the COVID-19 pandemic has disproportionately impacted young people's mental health. And we know that this is driven by a complex yet mysterious set of interrelated factors relating to social, economic, employment, educational factors. And we know that particularly sort of more marginalised young people are also disproportionately impacted, but also young people who have pre-existing mental health conditions. And so that's the area of interest for Answers. So next slide, please. In addition, we know as well that these problems aren't going away anytime soon. So this is a piece of modelling work that we did back in, April 2020, right at the beginning of all of this. Where we looked at the outcomes from prior pandemics and the sort of mental health impacts on the general population over time. And what we found is that the direct associative mental health impacts of any pandemic can last for up to 4 years, but it's particularly young people and those with pre-existing mental health conditions who are disproportionately impacted by these longer term impacts. And certainly this is something that we're seeing in practice right now. So our children and young people services are experiencing a doubling to tripling of referrals coming through right now. So we're right at the beginning, in a way, of these graphs right here. Next slide, please. But what we don't really know is really what is underlying all these changes in mental health, and also therefore what we can do about it. So we at the moment have a critical lack of intelligence in understanding the drivers of young people's mental health, and that includes what hinders but also what helps young people's mental health. So we are asking the questions, what is it that really on a meaningful daily level actually impacts young people's mental health from their own perspectives? Because we don't know that right now. How is it actually impacting, are these factors impacting young people's mental health, and why are these factors impacting mental health? And if we know that information, how can we then share that with health commissioners and the health system to try and bring together young people and health partners to come up with the solutions to really support the needs of young people together? So next slide, please. So the Answers project is effectively trying to answer those questions. And it's been very kindly funded by the partnership, and it's a collaborative between Norfolk and Suffolk Foundation Trust, partners from public health, children's services, social care, UEA, and commissioners and representatives from the integrated care system. And what we're planning to do, or what we're going to be doing, is working closely with young people to really understand on a meaningful level what these needs are, and bring them together with these commissioners to really find out how we can better support young people's mental health needs in this sort of post-pandemic period for the next 4 years. Next slide, please. So what we're going to be establishing is effectively a large-ish research cohort across Norfolk and Suffolk. So this will be 250 young people who are representative of the demographics across Norfolk and Suffolk, all of which have pre-existing mental health needs. We're going to be co-creating and co-delivering a study, a survey, along with potentially some qualitative work, which has been co-created with young people themselves, so that we know that we're asking the right questions which are of interest and of resonance with the lived experience of young people during and after the pandemic. We're going to be collecting this information across multiple time points, and we're going to be both comparing and looking at the changes in mental health across that time point, but also then bringing in the health partners and commissioners to really understand what this is telling the system about young people, and coming up with a list of recommendations about what is young people actually want and what they actually need to support their mental health. So this is effectively, we're right at the beginning of the project. We've done some preliminary work, which Bryony is going to be talking about. And if next slide, please. And the project, he can't be with us today, but the whole project is led by John Wilson, who is a consultant psychiatrist and the research director of the Norfolk and Suffolk Foundation Trust. So I think he sums it up really nicely here, that we are trying to fill what is a critical intelligence gap, but really from the perspective of young people, and bringing together the sort of chasm between our service users and our communities with our health commissioners and systems. So I'm going to hand over to Bryony now to say what we've done.
Thank you, Bonnie. So yeah, next slide, please. As Bonnie mentioned, we're quite early on in this process, but we did want to share with you what we have done so far and hopefully give you a bit of a flavour of the approach that we're taking to this project. So I've put last on this slide, actually, the involvement work with young people's groups. I think that probably should have come first because it was the first thing we did and has informed a lot of what's come afterwards. So we started by reaching out to youth involvement groups. So to the youth advisory boards via Joe Hand, who's been incredibly helpful in the process, to Educate at UEA, some local colleges. And what they were telling us was that actually young people are feeling quite survey fatigued at the moment, as I think lots of us can probably relate to. So we need to make sure that this work is really meaningful. So a very clear message we were getting is that we need to be able to demonstrate to young people that their voices will be heard and that there'll be meaningful change made as a result of the survey findings. The other thing that we're being told was that a lot of the work at the moment has focused on perhaps mapping out what are the impacts of the pandemic and sort of focusing on the negatives, but there's been less work so far focusing on the positives and what's needed now. So that's really shaped the way that we've been thinking so far. So next slide, please. So we've started off, and this is still open at the moment, but we just wanted to present some initial findings with a commissioner survey. So to be able to reassure young people that their voices will be heard and will result in change, we wanted to be able to tell them that we have engaged with commissioners and that commissioners want to hear these things. So as part of this survey, we've asked 3 very simple questions about what information commissioners feel they need about young people's mental health to inform their decision making in this post-pandemic recovery phase. So the first question was very simply, do you feel that you need more information about this area? And reassuringly, 100% of people who responded did say that they do feel they need more work, more information about this topic. Yeah, I guess that reinforces the need for this piece of work. If we go to the next slide, question 2. And then we also asked them to rank what they felt were the things that they needed most information on. So which topic areas would be most important to focus on. And the thing that's coming out on top at the moment is understanding what young people feel their needs are from the health and social care system. So again, very much chimes with the mission of this piece of work, which is great. And then next slide for the final one. So then we also asked a more open-ended question to give commissioners a chance to say what specific pieces of information they felt they needed. Just shared one particular quote that we thought was particularly kind of useful as an example of the sorts of things that were coming back. So in particular, asking what type of supports do young people value most? So is it that they want sort of mental health professionals, experts working with them, or is it that they more value peer support work, recovery focus, asking questions about where they want mental health support to be delivered? So is it within traditional mental health services, or is it more within schools, communities, primary care? So we think some really valuable insights coming up so far from this survey that we can then feed back to young people. Next slide, please. The next piece of work we've done is a scoping review. So we are aware that there is a lot of work that has been done at this stage to look at what the impact of the pandemic has been on young people's mental health. So really keen that we don't kind of reinvent the wheel here. We want to make sure that what we're doing is filling a really useful intelligence gap. And where, as we've said, we do think there is a gap, is focusing on what helps young people's mental health and what's needed in this recovery phase. So we've been doing a scoping review to see what's out there in the literature on that topic already. This is still ongoing, but so far it does feel like this is under research at the moment. We found quite a lot on what helped during the kind of more acute phase of the pandemic. So what helped people to feel connected, and also some interesting findings on how young people with pre-existing mental health difficulties may actually have been particularly well equipped to cope with the pandemic, having already developed kind of coping skills that were useful during that time. But there seems to be much less on kind of what's needed now and what positive steps can be taken. So we hope that we can fill that gap. Next slide, please. So as I said, this has all been informed by initial engagement, but we're hoping to do much more of that as we go forwards. So our next steps will be to bring the findings from the Commissioner survey and from the scoping review to our groups of young people, and to work with them to build the survey questions and make sure that the topics we're asking about are really meaningful to them, and also working with them to make sure that we can reach out to the widest possible range of young people so that everyone's voices can be heard. And then next slide, just the final one. So just to thank and acknowledge our collaborators. Working together across these groups is going to be really important in making sure that we can make changes as a result of these findings. We're really excited about the potential projects that could lead on from answers. And finally, just to thank the partnership for funding this piece of work.
Thank you very much, Bonnie and Bryony, for that presentation. It's great to see projects being profiled that are really making a difference to young people's lives, so important. So next I'm going to move on to Larissa Prothero, who's from Eastern Ambulance Service Trust. Larissa's going to be talking about the project Cessation. I can't even say it. Cessation is a tongue twister, which is female ambulance staff service experiences of menopause transition. So over to you, Larissa. Thank you.
Well, thank you, and I'd like to thank the partnership for inviting us to talk today about cessation. And if I can just have the first slide, please. Oops. Sorry, I think I've lost my internet for a moment. Can you hear me?
We can, Larissa, yes.
Oh, sorry, it was everything just froze, so I wasn't sure where I was. If you could just go back to, I'll just make my acknowledgements. If you could just, thank you very much. So cessation is a mixed method study of female ambulance staff experiences the menopause transition, so termed cessation. And our study team has involved both members of the research team, a community engagement group member, so a public member, and also we've had staff involvement. So we've hopefully had we've had good input from both public and staff members. Without the UEA funding, the partnership fundings, we definitely wouldn't be able to do this project. And it's as hopefully you'll see that we've made huge inroads into this relatively new research area. So thank you. Next slide, please. So for those of you that aren't aware, the ambulance service across the UK comprises about 40% of its staff are women, are female, as is the paramedic workforce. And most of these women are aged 40 years or more. Not surprisingly, these days, female staff are employed across a wide range of roles, both office-based and in patient-facing roles. Next point, please. Sorry, I've got some animations in my presentation. So just to confirm, the menopause occurs at the age of 51 years, and approximately 3/4 of women will experience menopausal symptoms. Next point. These will have a significant, or can have a significant impact on an individual's health and well-being to affect their workforce performance and attendance. Next point, please. And not only women of this age range can be affected by the menopause. Much younger women can be affected when they experience an early menopause or premature ovarian insufficiency, and also trans, non-binary and intersex people can experience the menopause. Next point. So currently there is very limited evidence regarding the menopause transition for emergency service personnel. What does exist is for our police and fire colleagues. However, we've been able to publish our pilot study, the Midwest study, that has enabled the initial development of cessation. Next slide, please. So the aims of cessation were to gather an evidence of menopause-related issues, improve menopause awareness, and inform the need for supportive menopause wellbeing activities and interventions in the UK ambulance setting. Next slide, please. So the methodology for this study has comprised 3 phases and has involved all ambulances across the UK. So that's 13 ambulance trusts to include 11 in England, and then you've got Scotland and Northern Ireland. So we've reached out to everybody. Phase 1, if you can, next point, has been a descriptive analysis of the UK ambulance health, wellbeing and sickness policies and guidance that refer to the menopause transition. Next click. So phase 2 has involved survey activity across all trusts. So all trusts, bar the East of England Ambulance Service, took part in the Cessation UK service, which was like a 22-question online survey. And this survey was based on our Midwest pilot survey. We then developed for the Eastern region a manager-only online survey, which comprised 17 questions to explore manager menopausal experiences and knowledge. And the question set was again based on our findings from the Midwest pilot. So everybody has taken part in cessation. And then phase 3 has been a series of virtual, either online or telephone interviews involving female ambulance staff in the menopause transition who identified themselves during the Cessation UK survey. Next slide, please. So we've got our results and data analysis well underway at this point. And initially, I'm going to just share with you the results of the document analysis, so phase 1. So across the 13 ambulance services, 8 of those were able to share with us their either menopause policy or guidance documents, which we've analysed. 4 services had no menopause related documents, and 1 service was unable to share with us with anything. And next click. And when we've looked at the content of these documents, they seem to be quite appropriate. So you've got information about menopause education, staff wellbeing and support, sickness and absence management, signposting to expert resources, and how workplace adjustments may happen. Next click, please. So moving on to the survey for the UK survey. So we received an amazing response. We received over 1,900 surveys to analyse. Typically, the participants identified as female were in the age range 45 to 54 years. And almost 60% of them were our patient-facing colleagues. Next click. And just to confirm their state of the menopause transition, so almost 35% were perimenopausal, with about 30 being menopausal, and then the remainder, up to about 90%, were either postmenopausal or not sure what actual phase they were in. So we've then, as one of the questions, we wanted to know what their menopause symptoms were and the extent to which they experienced those symptoms. So if I can have the next click, please. I hope you can all see this. So it's perhaps a little bit small. So we have a whole range of menopause symptoms, as you can see along the x-axis, and sort of the extent to which they've been experienced has been demonstrated by the yellow, amber or red for most severe. And if we can just click again, just to highlight the symptoms that have been experienced most severely by these staff members. So we have difficulty in sleeping, tiredness, low energy levels, mood changes, problems with memory and concentration, then your hot flushes and night sweats. So obviously these are things they're experiencing during their working days and home lives. Next click, please. So in addition to sort of the specific questions, we provided a free text comments box for participants to share any other information they wish to, and any suggestions for intervention support that they may find interesting, or sorry, of use in the workplace. So if we can just click on, we identified by a process of inductive analysis 10 key themes. So the first 4 I've grouped together as that either they related to the impact of their menopausal symptoms on their work activity, but also the impact of their working environment on their symptoms. Next click. We then have a group of themes that relate to basically improving menopause awareness, improving education and support for staff, which includes an appropriate menopause policy for both, in reality, both office-based staff members and those working out on ambulances, the patient-facing colleagues. And then just the final click. They also identified a real need for an improved compassion and dignity for or when managing women in the menopause transition. Crew room banter is not necessarily seen when allowed as particularly appropriate, and comments can be particularly derogatory. And it was highlighted that the menopause, going through the menopause, is a part of life. It's not a choice. So we've had sort of 670 comments that have really given some really good in-depth information for us. Next click, please. So moving on to the East survey, so the manager's survey, we received 123 surveys were returned, which represents 19% of our managerial workforce. And I think it would be fair to say there was variable knowledge and awareness of the menopause symptoms and menopause women's concerns by managers. But just wanted to highlight, so the managers' concerns, if we can just have the next click, kind of focused really on, they were concerned about staff personal health and well-being. We also see they have their concerns about sickness management and actually the lack of supporting trust, guidance and resources for managers and staff. Next click, please. They too had a free text comments box, and I think we received approximately 32, so 26% of participants shared additional comments, of which we identified 6 themes. And there was a significant amount of crossover between the comments managers made and the female participants. So these included a need for improved education, training and awareness, improved resources to support staff, access to specialist menopause guidance and professionals, so sort of you get the direct contact to sort of specialist menopause professionals. And they also identified, as the female staff members did, there needs to be a focus on improving male manager, I suppose, practice and knowledge around the menopause. So next click, please. So moving on to phase 3, so this is still work in progress. We've interviewed 23 women across the UK. If I can just have the next click, please. And all 4 stages of the menopause transition have been included in these interviews, and both basically patient facing, so your frontline operational colleagues, and office-based colleagues have been included in these interviews. and we've yet to complete the thematic analysis of these, but once we do, this information will be shared. Next click, please. And then just hopefully to wrap up my presentation, we just want to, we have a number of little recommendations from, or preliminary recommendations from this work. So obviously we're going to be making these findings available to all the UK ambulance services. We've already begun disseminating the findings, but we will be disseminating the findings further via suitable conferences and publications. Next click. There is a clear need to improve awareness around the menopause transition across all UK ambulance services, with signposting to evidence advice. Next couple of clicks. And then there are various service developments. So, for example, improving the office environment, improving uniform design to make it sort of lighter, cotton-based. Those kind of things that have been suggested by the participants should be taken into consideration as services move forward following the findings. And our plans are to convene a stakeholder panel to explore, discuss the findings from this study and to identify and aid the development of resources moving forward to support staff through the menopause. Then my next slide, please, is just a little thank you, and thank you again to the partnership for supporting this study.
Larissa, thank you very much. The female workforce in health and social care is just so important. So it's great to see the focus on our health and well-being, and to see the results of this project. Well done. I'd just like to say a massive thank you to all the presenters that have presented their work so far, and invite you all just to have a quick break so that you can move around and grab a cup of coffee. We are running over, so if we could just take 5 minutes, please, and come back at 25 past, and then we'll proceed with the remaining presentations. So look forward to seeing you all at 25 past. Thanks ever so much, everyone.
Hello, my name is Max Yates. I'm a clinical associate professor in rheumatology at Norwich Medical School, and I want to talk to you today about our project called SOCRA, which is Social Care Resource Use in Rheumatoid Arthritis. I'm sorry I can't be with you today, as I will be in clinic on Monday morning. The rationale for this work is that musculoskeletal diseases are the second most common cause of years lost from disability globally. And rheumatoid arthritis is the most common form of its arthritis, and again has long-term disability. With changing trends in the care of rheumatoid arthritis over the past few decades, there's been an advent in more effective biologic treatment, but sadly not cure, and so patients accumulate damage to their joints and associated disability over time. Now, little is known about the social care needs of these patients to inform best practice and to help support them, particularly within the home environment. Our previous work from our team has suggested that patients with musculoskeletal disease are heavily reliant on informal carers. Now, we're fortunate in being based in Norfolk is that the Norfolk Arthritis Register was set up in 1989 and is an inception cohort of inflammatory arthritis. The entry criteria are quite basic in the fact that patients need to be over the age of 16 and have 2 swollen joints in order to be recruited. So of those patients recruited, invariably a proportion of those will have rheumatoid arthritis. And really, we wanted to look at the social care use in this group of patients. Norwich Medical School at UEA co-hosts the Centre for Epidemiology versus Arthritis with the University of Manchester. It was Manchester University that originally set up the NOAR cohort back in 1989. And we're working with Jenny Humphreys, who is a clinical senior lecturer, so my opposite number, based up in Manchester, who has an interest in social care use. And she's also looking at the use of social care in amongst patients with rheumatoid arthritis, but in the northwest of England, in Manchester. And of course, we have Professor Alex McGregor, who is the chief investigator for the Norfolk Arthritis Register. And then to also look at the social care use as recorded by the council, we're also involving Aleska Cheeseman from the Norfolk Office of Data Analytics based at Norfolk County Council, as they need to collect this information when providing social care packages for patients in the community. Our proposed project plan comprises 2 work packages. The first will investigate social care use amongst patients currently enrolled in the Norfolk Arthritis Register. And this will be a cross-sectional survey on the current social care use and will be sent to all NOAR participants. The survey will be completed probably online, but will be available on paper as well for those patients who have a lower level of digital literacy, and will evaluate the health and social care needs and current levels of support and provision. As part of the survey, we'll also examine patients' willingness to consent to allowing access to current and future social care records. For work package 2, we intend to investigate the governance framework around linking the Norfolk County Council social care data set, which is recorded through a database called Liquid Logic, up to the Norfolk Arthritis Register. How will this improve the situation for service users, and what sort of outcomes can we expect? Well, data on social care usage is often missing in traditional assessments of disease burden. And when we're referring to informal care usage, there's no way of really capturing this without surveying the population. Who is the person that puts on the socks? And then understanding what the resource use is will help policymakers and providers of care, because they're able to better plan for what resource use is required. Secondly, we really want to identify those resilient individuals who seem to be coping at home despite all the odds thrown in their way. Through this, we then hope to identify strategies that these individuals employ, or perhaps even look at certain variables that are associated with resilience in a way of trying to understand what it is that makes these people resilient, and perhaps even be able to develop new interventions to promote resilience. Now, for the Norfolk Arthritis Register, having patient and public involvement is very much at the heart of what we do. And prior to the COVID-19 pandemic, in November 2019, we held a public science event at the Forum and invited all NOAR participants and members of the public who were around on that day to come and listen to talks by NOAR researchers about what the kind of things we do. The other thing is that we had a suggestion box for people to recommend different questions that they were interested in, or project or study ideas. And social care use was one of the things that featured. Subsequently, now coming through the pandemic, we've recently been involved in the UEA Citizens Academy, with the event held again at the Forum. And again, we had a stand there where we spoke to members of the public and patients about NOAR's programme of work. Now, we were awarded this money from UEA Health and Social Care Partners back in December. We had an ambitious timeline of 12 months. Now, we've been hit with a few challenges, which I'll elaborate on the next slide. But regarding the 2 work packages, for work package 1, we wanted to get the questionnaire out, then analyse the questionnaire and publish and disseminate the findings of informal care usage in amongst our patients registered on NOAR. And secondly, the second work package to establish the governance challenges, the research framework, and to devise a blueprint for linkage of the social care data up to NOAR. And following on from that, we would then think about a research for patient benefit NIHR proposal looking at social care resource use allocation. And we had an end date for November this year. What were those challenges that we've come across? Well, the Norfolk Arthritis Register was set up over 30 years ago in 1989. Consent standards, understanding and frameworks have changed considerably over the last 30 years. The Norfolk Arthritis Register is regularly linked to NHS digital data to capture mortality and morbidity data from hospital episode statistics data. And it was on a recent review that NHS Digital decided that it would be good for the whole NOAR consent process, and looking back over the last 30 years, for it to go to the confidentiality advisory group to see if the standards of consent, looking back through the lens of consent and governance frameworks of 2022, and how that looks compared to when we were collecting data in the 90s. They had concluded that for some years we did meet consent standards for morbidity and for others for mortality, but not over the entire duration of the project. As a result, they recommended that we seek Section 251 consent in order to have appropriate linkage for all these people. And this has been a huge task carried out by our database manager and by the wider members of the research team, and particularly, our database manager, Karen Durrant, and our senior research nurse, Jackie Chipping. And we heard back from the confidentiality advisory group on the 29th of June that they would submit a provisional favourable outcome in terms of our Section 251 application. Secondly, we have been in discussion with the Norfolk Office of Data Analytics, Alaska Cheeseman, and through her contacts with the council, it's decided that the best way in order to get access to social care data from the council is for us to give a pitch, as they are somewhat nervous about sharing their social care data, and understandably so. There's a lot of sensitive information recorded within their database, not least financial information, but also deprivation of liberty standards. The information that they record is through a database called Liquid Logic, and it contains a huge number of different fields. Of course, we need to convince Norfolk County Council that we will be asking for the minimal amount of variables required in order to assess social care resource allocation and usage, and for us to be able to look at the angle of resilience. Following on from the favourable CAG opinion, like provisional at the end of June, we hope to send out the questionnaire in August, and then we'll start analysis 3 months afterwards. So this project will require a no cost extension, but it is going ahead, and we're delighted to be able to be doing this work across partners within UEA Health and Social Care Partner Network, and it really will have a great impact and benefit for patients. I'd like to thank you all for listening, and I'll be delighted if anyone would like to contact me afterwards, and they're free to send me an email to my UEA email for that purpose. Thank you.
Welcome back, everybody. Hope you can all hear me. Very warm welcome back to you. Hope you all managed to grab a drink and have a quick break. We've run over slightly because obviously all the research that we've heard about has just been so fantastic. So we did have a recording from Dr. Max Yates looking at the SOCRA project, which is the Social Care in Rheumatoid Arthritis project. because Max couldn't be with us today, he's in clinic, and we'll embed that in the overall presentation, which will be available to you as a recording after this session. So we're going to move into our next presentation, which is from Professor Sheng Qi, talking about the regional NHS point of care 3D printing service. So over to you, Sheng. Thank you.
Morning, everybody. Thank you, Carrie. So I'm from the School of Pharmacy. So my project or our project is slightly different from the previous project people presented. We are really trying to build technological and service capabilities for our region. So I'm an engineer by training. That's possibly showed why I'm so passionate about 3D printing as a new technology arena which can serve multiple industrial sectors. Next slide, please. So just for people who not quite familiar with 3D printing, you might have heard it for the use of other spaces, but actually 3D printing has had quite a lot of use in the past 5 years within our healthcare services. And in some cases, social care services. So this is just one of the very exemplar kind of been publicized use. This 2-year little boy, Dexter, he has to have kidney transplant using one of his dad's kidney. But the challenge with the surgery is he's such a small person, and the surgeons was really not sure whether the dad's kidney would be able to fit into his tiny little body. And the 3D printing technology allowed the surgeons to print real life size of models of those organs, which will allow them to much more precisely plan the surgery, and the surgery was very successful. So this is just one of the examples of how 3D printing has been used in the past few years, mainly as models or organ models or tissue models, but it has evolved into now we are using 3D printing technology to print surgical guides and implants, which means those are literally the things not only for you to plan your surgery, but as well as aid you to be able to deliver a much accurate surgery with high precision. Next slide, please. So mostly 3D printing has been used in maxillofacial department in most hospitals. So those are for complex head and neck surgeries. But actually the first early adopters for 3D printing in clinical use are in dental space. So dentist has been using 3D printing for really quite a long time, over 10 years at least. And another big group of the adopter for 3D printing technology is orthopedic as well. So here are just a few examples. Next slide, please. So what is happening with our region? And this is really the reason why initiate our study or our motivation of doing this study. So our region has not been lagged behind in terms of using 3D printing technology. So particularly with our oncology department, they have been using 3D, and this is talking about NIUH. By the way, I should mention our project involves 3 NHS Trust partners within the region and external university, which is Loughborough University. So using NIUH as example, so our oncology department has been using 3D printing for over 10 years. Our general practice, still up to date, is using outsourced services from US, which they will do the online planning with our surgeons over the internet, and then any surgical guide need to be printed will be sent to Germany to get print. And this will involve a turnover rate around 2 weeks from the planning to receiving the printed part. And they have average cost about £3,000 per patient. So what we only explored at the planning stage of our project is only talking to our oncology department, which the estimation of the cases would need 3D printing services is between 100 150 per year. Next slide, please. So we quickly realized actually nationally, many of the trusts now is over 10 of our trusts, and still have many of them are planning to have their own on-site 3D printing services. These are mostly existing ones are embedded in maxillofacial department, from what we have been talking to them and what we learned is they all have very well agreed comment on in terms of benefit of you do have on-site embedded within the hospital 3D printing services. Mostly it's cost saving. They also agreed it does improve the clinical outcome and the patient satisfaction rate. So they really allowed the team, the maxillofacial and technician team, to integrate with the surgeons, and the surgeons can sit by them and do much more precise planning, as well as being much more creative and innovative in the kind of technologies they want to embed within their surgery. Next slide, next click, please. So Jason is one of the key person from Nottingham University, has been supporting us. So this is kind of through the project, the partnership we've been expanding. So Jason is the chief technician within the Nottingham University Hospital in the maxillofacial department. He's also the chairman for the Institute of Maxillofacial and Prosthetists and Technologists. What he has been telling us in terms of national trend is the Institute really want to recommend the future national operational model is you do have regional hub. And that really goes very well with what we have been thinking, or what this project is really trying to support our hospitals in the region to do, is be able to set up our regional hub, because our closest 3D printing on-site service is actually based in Addenbrooke's in Cambridge. Next slide, please. So this is what our project trying to do. We wanted to help, and we are currently doing. The project started the end of April this year. So we wanted to support our NAUH to be able to set up on-site 3D printing service for clinical use. The critical point of being able to set up the service within the hospital is you can bypass many regulatory and cost barriers. Within the regulatory requirements, if the prints are generated within the hospital, actually you would not need a lot of additional regulatory approvals in comparison to if you are receiving those from outsourced providers. We also would like to set up offsite using the advantaged expertise and resources we do have within UEA. For example, our Productivity East has a rich resources and facilities in terms of additive manufacturing and 3D printing to allow us to build kind of R&D supporting side at UEA to help our regional hospitals and clinicians to innovate and take their ideas into the prototype stage, and then fast forward move them into commercialization. Next slide, please. So the benefits to our regional partners, we really do think, and these are not benefits we're predicting, these are the benefits we collected from talking to other trusts who already have embedded 3D printing services in their hospitals. Most important is cost saving, and we actually through our workshops and through talking to many of the chief technicians, they are very attractive numbers they can put down in terms of the cost saving they can generate for their hospitals. They also said, you know, very much providing their surgeons with much more confidence and precision for their surgical procedures, which also in most cases lead to reduced surgery theatre times, which is a number very difficult to calculate, but it has a knock-on effect in terms of cost, as well as how the speed we can move more patients into their very much delayed surgeries, particularly post-COVID. they also find a lot of cases the 3D printing service, when they're not printing surgically needed guide and tools, they are printing models for the surgeons to plan their surgery, as well as allow the surgeons to communicate with patients in terms of how their surgery procedures will be proceed. And the feedback they get from their patients is it does provide patients with much more confidence with their surgery, and in general their patients are much more happier to go into the theatre. In terms of our offsite R&D services, we really want to use this as a service which can promote the collaborative research between clinicians within our region, as well as the academic staff at UEA, because we think there's a very much rich supporting technology and resources and expertise we can provide from UEA. Next slide, please. So just to quickly go over what we have been doing so far. So we have been continuously collecting surveys from surgeons. So these are the surveys has been sending through multiple trusts within the region. The survey is targeting surgical staff who either have been using 3D printing services or know very little about them, but would like to know a bit more. So we have been continuously receiving feedback from the survey. And in fact, one of the feedback from the survey actually led to a case study, which I will talk very briefly in the next slide. So we have received a great support from other trusts. So we have visited Edinburgh's 3D printing team, as well as Leicester and Nottingham University Hospital 3D printing team. So those are the team. So Leicester and Nottingham, they have been having their 3D printing services on site within the hospital for over 10 years. So they are national leading and very experienced. And they have been very much supportive. What we have been working with them for is really trying to understand how they were able to build their business case and translate those information and communicate those information with our maxillofacial team at NAUH to support them to build their business case for putting the case forward for building our own on-site service. Next slide, please. So we have run our first workshop event on the 3rd of March this year, which is in person and online both. So we have received external as well as internal participants, and we engaged with industry partners. So Stratasys and Materialize are the two key industrial partners for many of the hospitals who has their 3D services. We're not saying these are the ones we will be using, but they are very critical in terms of allowing us to know what is available in the commercial space and allow us to better make our decisions. So we have also, through the survey, as I mentioned earlier on, be able to identify a case study, which this will be our first kind of pilot joint R&D project, which we would be able to move forward next. And this is with our NAUH breast reconstruction and surgery team. What they have identified is 3D printing potentially could help significantly improve the surgical procedure for a breast cancer patient for their breast reconstruction. So every single one of us possibly know somebody has experienced breast cancer, and 40% of breast cancer patients would have their breast removed and be offered with reconstruction surgery. And these surgery are very lengthy because currently there's no precise way be able to measure the flaps and skin needed for the reconstruction. So many patients has to have repeated surgeries to get it right. And each of time of the surgeries, patients need full anesthetic for very long period of time, and they need to be in hospital, hospitalized for at least 1 to 2 days, followed 4 to 6 weeks of off work. So this is really have a long knock-on effect. So for the workforce. So if we could have a digital tool allow us to precisely predict how much tissue and skin would needed and where those tissue and skin would come from before the surgery, this would really reduce, shorten the theatre time and really improve the surgical outcome. This is in the slide on the bottom right. I'm showing what we are planning to do is using the digital 3D tools, be able to accurately calculate how much flap volumes would be needed during the surgery process. We also would be able to print a mold of the breast to match with the existing breast, as well as being used to measure out the tissues during the surgery time to speed up the surgical procedure. Next slide, please. So finally, I just wanted to kind of restate our vision in terms of this project. We really would like to support our NHS partners to build our original 3D printing services so we don't have to rely on very expensive outsourced services, so we can be independent, as well as supporting our regional other trusts if there is other needs from other smaller trusts. Longer term, we really want to build the unique regional capability in 3D printing, because they are way beyond the examples I've been showed here in terms of how 3D printing could support surgery and medical services. Finally, I just want to thank the team as well as the UEA and HSAP team and the funding. We won't be able to deliver the project without their support. They have been extremely helpful to helping us in getting in touch with all the trusts and communicating with them and many admin roles as well. So thank you very much.
Sheng, thank you very much for that very inspirational presentation, and I'm sure everybody here can hear the potential application of this technology. And I myself had the privilege of coming to your March workshop and was completely blown away. So we're delighted that the partnership has been able to fund this work, and long may the innovation continue. It's a great profile for all of the people that live in our region and will help to support organisations in the integrated care systems to use their facilities more effectively to speed up that surgical process. So thank you very much, Sheng, for your presentation. So I'm going to move now into our final presentation from Professor Caitlin Notley, who's going to tell us all about the UEA Citizens Academy. Thank you.
Thanks, Carrie, and hi everyone. It's fantastic to be here and be part of this launch. I've really enjoyed hearing about all the fantastic projects that have been funded through the partnership, and really, thrilled to hear about the integrated approach to patient and public involvement that all those projects have included. So I'm just going to talk to you a little bit today about our Citizens Academy. I know many of you are aware of this initiative, so I'll try and be brief, and then we'll have time for a quick Q&A at the end. As Charles kindly said at the beginning of the morning, the Citizens Academy is really key to supporting the infrastructure for developing research in our collaborative research endeavours. It's not a new idea. It's arisen from many years of really good practice across the Faculty of Medicine and Health, and concerted efforts by our esteemed colleagues in integrating patient and public involvement into the faculty, and that's across teaching and research. So the Citizens Academy is really the result of a co-produced consultation exercise resulting in the report of a task and finish group that reported in 2019. So as a result of that, here we are now. The Citizens Academy is our coordinated effort to integrate patient and public involvement across both research and teaching. What we do is provide a central point of contact for academics, educators, colleagues, partners across the health and social care partners, to provide support, advice and guidance on working with members of the public and patients. We're a central point of contact, so we have a website, a way and an email address, a way that you can contact us if you're seeking public involvement and you need advice and support. Also, of course, for members of the public wanting to get involved in research, particularly, or of course in teaching, but I'm not focusing on that today. So what we can do is signpost to existing service user panels. There's excellent panels existing across our region and across the partnership. We heard, for example, about the Youth Advisory Board, who are doing fantastic work in youth research. Many other panels focused on particular clinical conditions which might possibly would be relevant to your work. And then also we have our own service user database, which is a fantastic resource of people who have agreed to share their details and relevant experience and have a wealth of experience in being involved in teaching and research already. So if you have an idea for a research project, we can contact that service user database and seek specific involvement if that's something that would be beneficial to your project in development. So the Citizens Academy really is about facilitating those reciprocal relationships between members of the public and patients and UEA faculty and obviously our partners across the patch as well. Somebody described it, I think it might have been Carrie actually, as a sort of formal dating agency. I see it as a bit more formal than that, but on a basic level it is about joining people together, allowing members of the public and patients to meet with researchers and help them in developing their research ideas and indeed delivering research. So we can offer training, we can signpost to training resources, we can offer support to research teams and to members of the public. We have a new mentorship scheme, which is just getting off the ground, and I've just been linking mentors up with someone applying for a fellowship over the weekend. So that's really fantastic development. And obviously, we also have lots of involvement from our very proactive steering group and working groups working on specific areas of need. Next slide, thanks. Just to give you this a quick screenshot of our website. This is in development. It is openly accessible to all. Have a look at some of the research case studies posted on there. Particularly, I encourage you all to engage with the involvement opportunities section of the website. We really want to grow that and it to be a thriving, active place that people can look at to see what project opportunities there are to get involved in. So this is for the public to look at what involvement opportunities there might be. So obviously I encourage you all to get in touch and we can post relevant projects there seeking involvement opportunities. Next slide, thanks. So some key challenges for our Citizens Academy, and I think these are challenges for all of us across the partnership in undertaking research work, are about engaging with those groups of the population who have perhaps historically been more difficult to engage with. Public and patient involvement opportunities have perhaps been criticised in the past as not really engaging and accurately reflecting the population that we serve. This means that we need to do more in reaching out to those groups to engage with diverse voices, working in an agile way to seek different ways of engaging with people who perhaps find it difficult to engage with the work of researchers and educators. So we're really actively working on developing stronger relationships with those who are seldom heard, trying to, as much as possible, really value everyone's voice and knowledge as having equal expertise. And this means that we need to work on different ways of engaging and meet people where they are. So particularly focusing on kind of community-based approaches and offering people opportunities for involvement that work best for them. So recognising that the PPI process is really a reciprocal relationship. Next slide, thanks. So we formally launched the Citizens Academy only back in May this year. Already seems like a lifetime ago. Next slide. Just wanted to talk about this as it was a fantastic event where we were really successful, I think, in bringing together the local community with researchers and educators. We had over 4,000 people passing through the forum that day, and 16 research teams, as well as the local trust represented at the event. So it was really a unique, special opportunity for the launch and an ability to engage with the public. So it did also very positively result in many inquiries to the Citizens Academy. We have a few new service users signed up to the database as a result of hearing about the work of the Citizens Academy that day. So this was really fantastic, and we hope to do much more of this in the future. And as Carrie mentioned, next year we plan a co-produced joint conference where we will be working with service users to really showcase the co-produced research and service user-led projects that we will be involved in over the coming year. So really look forward to that. Next slide. So just to finish with the final few words about the way the Citizens Academy and the Health and Social Care partners particularly are working together in collaboration. The Citizens Academy, we're here to support partners across the partnership in developing funding applications. Particularly that might be about engaging with members of the public and local communities in developing research ideas, supporting teams in how to undertake that engagement and how to integrate PPI into research applications. So providing some infrastructure and support also for PPI members. And this is around training and mentorship of to give people the skills and feel encouraged and enabled to be able to contribute in a meaningful way. We can help with defining service user-led research priorities. We can put specific calls out to our service user database, and also more widely using social media to get active feedback from members of our community on what is important to them. And just to give you a flavour of how busy and active we are already, currently we're involved in 4 NIHR PhD fellowships, 2 Stage 2 NIHR bids and 3 Stage 1 bids. So really fantastic to be able to support projects in development, and then once funded, hopefully to support the ongoing patient and public involvement in delivering those research programmes and also disseminating the knowledge. Beyond the funded research, though, it's really important for the Citizens Academy to be able to support early stage grant development, including PhDs and small projects that perhaps come before the larger funded studies. And this is really important because that infrastructure hasn't been there in the past, particularly in things like supporting payments for PPI members outside of a funded grant application. So here at the Citizens Academy, we are able to offer that support, recognising that patient and public involvement is absolutely essential right from the very early stages of grant development. And then finally, just to announce that we hope to be announcing a co-produced community-based research call later on this month. So watch this space. This is going to be small pots of funding for co-produced community-led research led by service users, but really importantly, before we announce that, we're going to be putting in place the infrastructure to make sure community groups feel enabled to apply for that research funding and then supported to be able to deliver the research project that they propose, and also to actively disseminate findings. So excited to be announcing that, and watch this space for further information. Final slide, thanks. Just finishing up with a few contacts there. Please get in touch. Any questions, we're really happy to engage. And thank you so much for your time, Carrie. I'll hand back to you.
Thanks very much, Caitlin. It's just great to hear about the work of the Citizens Academy, and we're really looking forward to working really closely with you in the coming year. I think it's going to be very exciting. Thank you, a massive thank you to all our presenters. So I'm just going to run through a quick list before we go to some quick questions. I'd just like to acknowledge Professor Dylan Edwards and Mark Hitchcock, who were the founders of the partnership. We're delighted to be able to build on the foundations of the work that's already been achieved. So today wouldn't be possible without acknowledging them, and of course the wonderful Health and Social Care Partnership team. So that's Heather, Bianca, David and Sarah Walker, who's recently joined us, and Joe Fitzsimmons, who's moved on to a job at the QEKL, but we couldn't have done this without him either. A massive thank you to all our collaborators and presenters this morning, and to all our research groups in the Faculty for Medicine and Health Sciences. We've got 16 groups. And to Charles and Sally, thank you very much for your support of the partnership, and for me personally taking over and having to fill some very big shoes in 2 days a week. I'm very grateful. So I'm just going to go to the chat, just invite all my co-presenters to come on screen. We've had one very good question in the chat here from Nicholas Walsh, who's asking us about our ability to actually involve social care, that we're not just focusing on health and medical problems, but also social problems that go beyond the normal boundaries into broader systems. That's the first one. And also how we are dealing with survey fatigue, particularly where we need to gain access to groups of people where there may be access gatekeepers. So I'm wondering if any of my colleagues would like to address either of those 2 points.
I think to some extent they were kind of both brought up during our sort of presentation about answers. I think the first one is that's exactly the point that we're trying to do with the project, is trying to identify and work out the impact of different and quite a broad spectrum of holistic social factors which are impacting, in our case, young people's mental health. And that's actually the kind of more the point of the project than a pure sort of medical kind of health related sort of measure that we're doing, which has been done 100 times before. Bryony brought up the survey fatigue, which is what's been reported to us by young people. I think in terms of the pandemic, you had a lot of bored researchers at home during the initial lockdown, and everybody got spammed with hundreds of these surveys, which a lot of which were kind of validated measures, levels of anxiety, levels of depression type of things. And you are perfectly right. There's been no inherent change to that, but there's been no implementation of those outcomes and findings into anything which has actually helped young people, apart from making people aware of the problem. And so what we've been left with is a group of young people who've spent hours of their own time filling out these surveys for different people. None of it's come together, none of it's made any change. So that's why we're involving young people in our project very, very early on, to make sure that we are asking questions that they actually want to fill out and that they can see the value in that. So that didn't answer the whole question, but that kind of is, I think, our perspective of where we're coming from.
Really helpful, Bonnie. Thank you. Bryony, did you want to come in there and say anything?
Yeah, I was just going to say, I think Bonnie's answered it really well already, but just to say that I think it perhaps relates to a broader issue with research implementation. We often do research projects, write up the findings, publish them, and then aren't able to implement the findings from there. So I think the partnership can be a really important part of sort of bridging the gap and making sure that research findings do get implemented and impact practice and impact people's lives ultimately.
That's lovely, Bryony. Thank you. And Nicholas, I think what you'll start to see is with the Citizens Academy, the UEA Health and Social Care Partners, and co-production Norfolk, just as one example, through the Norwich Institute for Healthy Ageing, so reaching out to lots of different groups and organisations in the integrated care system infrastructure, and working very closely with both county councils in Norfolk and Suffolk. So I think we've got some great stuff going on. It's always going to be a challenge, but actually to overcome those challenges, doing it together and working collaboratively will enable us to have a greater reach. and I think will enable us to actually innovate the sorts of methods that we're using. And you've heard today that there's a lot of creative, artistic methods that are being used with people to help them get involved and engaged in a lot of the work that we're doing. So a massive thank you to you all, to all of our presenters, Wendy, Simon, Ella, Bonnie and Bryony, Larissa, Max, who you will be able to see his recording later, Sheng and Caitlin, and to the team, of course, and to all of you for coming into the space today. The recording will be available to you all. The report has just been launched in the chat. It's also available through Twitter. Thank you very much to everybody for the lovely messages we've received so far. You can contact us. Obviously, on this slide, you can see our email address, and you can follow us on Twitter. And watch this space. There's going to be lots of very exciting things happening. The results of the latest funding application will be known later on this month, the week beginning the 18th of July. So there'll be some news about new projects that we're also funding through the partnership. So thanks very much, everybody, for your time today. Thanks a lot.